So welcome to Breakout Session 3 on equity in supply chain. My name is David Kaslow, and I'm the Chief Scientific Officer here at PATH. And if you intended to participate in the data sharing or the finance breakout sessions, there should be a button at the bottom of your screen for Breakout Session 1 for data sharing, and click on Breakout Session 2 for finance. This breakout sessions, we're going to focus on equitable access and allocation of medical countermeasures, be it the diagnostics, drugs, vaccines, medical equipment, personal protective equipment, and all kinds of other critical supplies. We've actually got a great global trio panel today to address the global problem of equity in the supply chain. I'd like to start with just a quick round of self-introductions by Ben and Meseret and Mark, who had asked to let us know where they're working and how their work has changed because of the ongoing pandemic, and then to declare any conflicts of interest. After that quick round of self-introductions, we'll then dive into the first question, which should really help us define what's the problem statement to frame the next 45 minutes worth of informal discussion. While we're doing the introductions and throughout the next 45 minutes, please do submit questions that you'd like the panelists to discuss. So, Meseret, let's start with you.
Thank you. Good afternoon. I'm based in WHO, Zimbabwe. I'm working in the sub-region where we have 20 countries in the East and Southern Africa. I'm an immunization officer for the World Health Organization. Today, I'm representing my colleague, Phionah Atuhebwe, from the Regional Office for AFRO. So they're deeply involved currently with the COVID-19 vaccine from the start up to operations that we are monitoring at the moment. Thank you for having me.
Thank you, Meseret. Let's turn to you, Ben.
Thank you, David. My name is Ben. I'm the Head of Health and Care at the IFRC International Federation of Red Cross and Red Crescent Regional Office based in Nairobi here. So my responsibility entails public health programming across 49 countries in sub-Saharan Africa, supporting our national Red Cross societies to deliver essential services to their national governments as auxiliaries to their national authorities.
Great, thanks, Ben. Welcome.
Thank you.
And then to you, Mark.
Yes, Mark McKinlay. I'm the director of the Center for Vaccine Equity at the Task Force for Global Health in Atlanta. Our programs involve everything from hepatitis B and C, polio, influenza program introduction, but now also introduction of COVID vaccine into 50 LMICs.
Great. Welcome. Welcome, Mark. So I suggest let's start by framing the equity and supply chain problem statement. First, by maybe capturing some of the lessons you all have learned from being involved in the COVAX pandemic response, and where you see the greatest gaps that are occurring in the supply chain. So maybe Ben, maybe lead us off.
Thank you. I think from what we see at present in terms of how the vaccine allocation has been done at country level, we see clearly the priority group for vaccination are the frontline health workers, people above the age of 50 in some countries, and also the people with comorbidities. So the issue here is, of course, you know, frontline health workers. I think identification of this group is very easy. Then when we talk about the priority group, population above 50 or with comorbidities, how do we identify these groups with respect to people who are in refugee camps or in other rural areas? How has the population census or information or data available captured the existence of these people to ensure that they are properly targeted and access to get these vaccines? So these are questions that I think need to be answered when we talk about the hardest to reach people, how the vaccine has been able to reach these people, knowing fully well the contextual difference with respect to having precise demographic information in low and middle income countries or many countries in Africa. How do you target and access these populations that have comorbidities and above age of 50 who are in certain geographies or maybe situations like camps to get the vaccines? So this, I think, is something to reflect deeply on and maybe ensure we plan very well against such issues.
Great, thanks, Ben. So reaching those the hardest to reach is a huge gap, obviously, for us, and obviously provides a lot of issues around equity in the supply chain. Maybe Meseret, your kind of lessons learned from being involved so far in COVAX and where you see the greatest gaps as it relates to supply chains. Just to frame the problem a little bit, and you're on mute.
Thank you. Thank you. Really, the supply, while it's an issue that we don't have it in enough quantity, it's highly needed because the pandemic has affected all. It has knocked every door, every country. So, but these are scarce vaccines at the moment, but definitely identifying the risk groups, the priority groups has been also a challenge. It's not easy. Which groups are with comorbidities? The identification itself could be a challenge, as most of the non-communicable diseases may not have been even diagnosed in our settings. In urban areas, in towns, it could be easy. However, even the identification of those people to make the diagnosis could be difficult. But lessons from experiences have showed to work with the communities. And our national immunization technical advisory groups were also very handy where they exist, really, to guide, either use age cutoff. This could be the comorbidities where they are. So that's one. The second, like my colleague said also, is where are the hard-to-reach communities? We talk of universal health coverage. We talk of equitable access to health service delivery. However, the health systems are limited, really, especially in the African setting. Most of our countries have infrastructure, human resources, also outdated census, where sometimes they are not even reliable for you to use. But through the experience of the micro-planning, population figures coming from the lower, which feeds up to the national level, countries have tried really to plan and identify these risk populations. But those two I want to put as challenges. Thank you.
Great, thank you, Meseret. Mark, your thoughts in terms of kind of where those gaps are and any lessons learned so far?
Yes, I guess one of the ones that I'm seeing firsthand with polio, particularly in Africa, is the impact that the COVID pandemic is having there in terms of surveillance, getting the campaigns initiated, et cetera. So that's been pretty impressive, but also to see the collaboration between the polio teams and the COVID vaccinators and seeing these groups come together where in the past they might have worked more vertically. The other thing that we're learning, because we're involved in vaccine hesitancy, is just the magnitude of that effect and how great that is, particularly as you go across different countries. And I think one of the discussions in the prior session is the fact that maybe if manufacturing is done more locally, that would reduce the potential vaccine hesitancy in different parts of the world. So those are a couple of my observations.
Great, thanks. So what I think we should, let's dive into some details here, right? As you know, we look at influenza preparedness, there's a variety of medical countermeasures that need to be considered and brought to bear and that sort of thing. And I guess it would be good to get each of your thoughts on how do we address the equitable allocation and the use all the various medical countermeasures that need to be brought to bear. We're facing oxygen shortages and ventilator shortages, and access to things like monoclonal antibodies and personal protective equipment and other things. So, your thoughts in terms of how should we be going about, or how should we address the equitable allocation and access to all of those different countermeasures? And maybe I'll turn to you, Ben, maybe first, in your role in terms of how your organization and how you are thinking about how to address that access and allocation issue.
Yes. So first, talking about the access issue, I think this is spillover from discussions around local manufacturing of vaccines and other products. So I think, as was said in the previous panel, I think this is a clear response to the debate that has been going on, that we need to invest in the capacities to produce these materials locally. For instance, we agreed, vaccine, not every country should be able to have manufacturing capacity. Maybe better to have centralized regional hubs where economics of scale can be produced. But if we go down to things like the PPE or the ventilators or oxygen, I think these are things that can be produced at the local level. We've seen innovative ways that people have produced locally made improvised ventilators. We've seen PPE manufacturing at local level, simple technology. This is what's required. So I think the future is investment in the simple technologies that are required to produce at least the most basic of these, the PPEs, the ventilators that can be adapted to local context. And so for me, I think it requires commitment both from the government to first and foremost promote indigenous and local innovations, and investments in these innovations to go to scale will be critical to ensure that first and foremost, the production is enough within the country, within the local country. Then the allocation then can be equitable in that context, because we've seen the challenges of relying on importation for even PPE at some point. There's a scarcity of that when once reliance was so much on importation. But once local production took over and innovative materials were being used to produce locally, we saw that these things were now in abundance and accessible to most of the people. And we could see local production of masks using local fabrics that was acceptable and protective as it should be. So I think he's thinking of investment in local production, innovation, and low-cost technology to move forward with the basic medical products that can be done. And then the higher level, like the vaccines and others, we can see how to invest in regional production hubs that would ensure availability once the market dynamics are well defined within our context. So this would be my suggestion.
Right. So I guess what I'm hearing you say is, depending on the countermeasure we're talking about, some of those are local and bespoke. Others are regional and more coordinated. Mark, your thoughts on this?
Yeah, I mean, that's very comprehensive in terms of the manufacturing, et cetera. But one other idea that we've used in our flu program is pooled procurement. So getting a group of countries together to increase the demand. So we've done that, like I say, with the influenza vaccine. And I could see that for all these different products here could be a possibility.
Yeah, no, so as a kind of an aggregator, but the question I guess I would have to you is, how do you then allocate? And are there thoughts in terms of how you do, or is that, you got a separate governance structure and that sort of thing?
As the group comes together to do the pool? Absolutely, that's the challenge. That all needs to be understood and agreed up front. Exactly.
In advance. Thanks.
Yes.
Meseret, your thoughts on either supply, access, allocation?
Thank you very much. I think complementing my colleagues in the panel, I support that the call for vaccine equity should also be accompanied by a commitment to knuckle down and make the best of what we have. I think encouraging suppliers, with those with extra capacity to support, could prioritize and also support targeted needy countries in Africa, for example. The commitment to like agencies or like through COVAX facility could really help address, because it's a platform that has so far been successful for the vaccines, and probably that's where we could also put. WHO is also supporting to increase the oxygen production capacity at country level by supporting plants in some countries, and also delivering around 3,500 oxygen concentrators to high-risk countries. This is also based on prioritizing the countries, but also collaborating with African professional medical and nursing associations in the critical care training. I think my bottom line would be then collaborating and really bringing the suppliers to a center stage. That way, I think we can address the needs, even in this needy time. Thank you.
Great. So let's say we've aggregated, got all the materials that we need together and that sort of thing, and we've figured out how to allocate them. Let's go back to I think the point that both Ben, you made, and Meseret, you mentioned this earlier, as well as these hardest to reach populations. What do we need to do? What are things that need to be considered in how to reach those populations? What are the tools and the preparedness that needs to happen? And it would be good if you could identify and say, it would look like this if we're trying to reach, refugee camps or migrant populations or rural places, or is it all kind of the same? And so, Meseret, maybe we'll start with you and then go to Ben and then Mark.
Thank you so much. It's a very interesting question. Yes, from the outset, for the World Health Organization, helping the countries develop their national employment and vaccination plan, the equity has been really in standard manner put out in bold to ensure that, be it migrant, refugee, displaced population, it doesn't matter, they have to be identified in the host country and provided the access to the vaccine. So there are standard tools, definitely. We call them micro-planning. So it's within the community that they have to be identified. So we've encouraged countries to really identify them with support of agencies like IOM, UNHCR. And let's not also recognize within the African region, Eastern Africa, around the Great Lakes, is where we have a largest number of refugees. But what we could say is, on the 150 countries who have submitted this plan, National Deployment and Vaccination Plan, at the global level, 106 of them have clearly outlined they will identify them to reach them. So the tool is there. Now, as in the phased introduction, it may not have been much of the healthcare workers, but as we move to phase 2, when we vaccinate those with comorbidities and also the elderly, these are in different populations. So the hard to reach communities, we've been using the example from the polio campaign, the yellow fever campaign, meningitis phase introduction. Africa is rich in the capacity or in the experience of introducing vaccines, but targeting them is one, identifying them is second, but reaching them, that's where the challenge is. Exactly. Transport, you need extra airlifting. Think of South Sudan. Think of DRC in the remote areas, or Ethiopia. The pastoralist communities, you have to target them in a certain way. Experience is there, but it needs more resources and it puts pressure on the existing health service already. But outlines are made, and we hope that they will be reaching them. But we already know certain countries have already started vaccinating refugees. Migrants may be tricky because they may not be documented, you see. So, but all countries are trying to work. The monitoring is happening. So we will see continuously how because we don't want them to fall into the cracks. If we don't reach everybody, that single person could provide risk to the communities. That's the approach we have been using. Thank you.
Thank you, Meseret. Ben, your thoughts on things that we should be considering and be prepared for in terms of, reaching these hard to reach populations.
So very much in agreement with Meseret, and maybe just to add a couple of maybe 1 or 2 points in terms of preparedness and getting ready. She has mentioned it via the process of microplanning. We need to have very robust data. We need to have information about this key population. And very much important with respect to this is ensuring community involvement or community engagement, ensuring the population themselves are deeply involved with respect to how these data are collected, how they are managed. And this is from our experience as Red Cross, Red Crescent that work with communities. When they are very much involved and engaged in the processes, it's easier to manage and it's more sustainable, and you are likely to address most of the challenges with respect to having access to this population. So this will be one a recommendation I will put on the table with respect to that, involving local organizations and to ensure community participation and population engagement. Then the second would be with respect to leveraging on private sector capacities, especially to address the logistic challenges that have been mentioned by Meseret. We know when we talk about private sector, our minds go to the bigger companies or the Coca-Colas or others at first. But when I'm referring to private sector, I'm also referring to the small and medium scale enterprises that exist within these societies and these communities that have assets that can be leveraged on, that have products and services that are of importance and value to this population, that also ensures that we are able to connect via their products and services to this population. So this is what I will be looking at as also a potential recommendation with respect to addressing the issues of last mile. Because as an example, you are talking about a refugee camp. In the refugee camp, people utilize soaps, people utilize other kinds of commodities, just to give an example. So walking through people who get these commodities to those population is also very important. And yeah, this will be my contribution to this. Over.
Before going to you, Mark, maybe just a quick follow-on question, Ben. Your thoughts in terms of, and we'll come back to you on this question as well, Meseret. The community's acceptance of doing, tabletop exercises or practice of preparedness and that sort of thing. Is that something that would be accepted? Is that value added? Do we do enough of that?
Yeah. So we are not doing enough of that, but we have experience from Red Cross, Red Crescent Society working somewhere like here in Kenya, where we have been able, via an initiative we call the Community Pandemic Preparedness Program, work with communities to plan surveillance activities together for early detection and response. And we have done that in some communities in Kenya here, where most of their livestock are prone to anthrax, and the community members who previously could not identify signs of anthrax in livestock, we're now able to identify. Previously, they used to maybe consume these and these affects the population health, but now they are able to effectively identify that this is anthrax and know the measures to take, report to the health authorities, appropriate response action is taken under the One Health framework. And yeah, so we have seen that working, but we are not doing it at scale. And bringing this kind of community participation and engagement to scale, I think, is key for us moving forward.
Great. Mark, your thoughts?
Just to add to the comprehensive answers there, in terms of engaging the immigrant population, is in those countries where they're not provided health care, is to really make sure that we put together culturally appropriate, the right language, et cetera, to engage that population. That's the only thing I would add. Thanks.
Great, thanks, Mark. Measure, your thoughts, just to close out this question, I want to come back to you in terms of your thoughts in terms of community acceptance and interest in quote unquote tabletop exercises and preparedness exercises and that sort of thing. Is that something of value or not?
It is, specifically with regards to the tabletop exercises. It was used mostly at national level, probably provincial level, to really using even the virtual platform where they had access. With regards to going down to the level of the communities, whenever they engage them for planning, for messaging, you'll be surprised they are so well organized. Go to Eswatini, the chiefs are very much listened to. In Botswana, the same. So the traditional leaders, the religious leaders, very exemplary, religious leaders being vaccinated, then followed by the pastors at the different level also, encouraging the vaccine uptake, wherever they are engaged. And in principle, we should, but we may not have done it to the maximum. We may not all countries may have used it exhaustively, but the tabletop exercise was used in training, usually not beyond district level, towards the community. Thank you.
Great, thanks. This is just a real quick call out to those who are listening to please do send questions in. We're monitoring the chat here and can address those questions. What I think I'll do now is turn to do vaccine questions. And maybe start with you, Mark, with the first one, which is vaccine expiration is an issue. Although currently, some of our vaccines require ultra cold chain, although I think we're encouraged by some recent news that one of those ultra chain is actually now considered stable at refrigeration for a month, up to 31 days. But still, that's something that resources and rich countries can address. But countries with less resources, this is a big issue. And so kind of your thoughts on how do we solve this problem in the future, and how do we deal with the issues that have recently come up with higher resource countries taking vaccines that are reaching expiry and then sending them out.
Okay, good, great question. And one of the issues, of course, is there's limited data to justify the expiry initially with a new vaccine. But as you're seeing with some of these vaccines, as they're generating additional data, they're pushing the expiry date out. So, I mean, that's really the key there, is to keep generating that data, to keep pushing the expiry date out. Then in terms of cold chain, obviously we have new vaccines coming along, like CureVax is going to be refrigerator storage. So we're going to have the capacity here going forward to have vaccines that don't require, -70 storage. Thank you.
Great. Thanks, Warren. Ben or Meseret, you want to weigh in on the expiration issue of things? Okay, so both of you, we'll start, Meseret, we'll start with you and then go to Ben.
Thank you so much. This is a great question. Yes, it's of concern. As you all know, all the vaccines were given expiry dates within 6 months, because the data was limited by then for 6 months. That was what we knew. So, and the advanced need of use or the urgency also pushed this. So countries received with short shelf life, but WHO is going to review with full data, and hopefully in the next vaccines that are going to be released, we may expect a longer shelf life labeling. So, but currently, WHO and COVAX partners have supported through the plans to monitor closely so that vaccines should not go to waste. And the dose sharing approach also was an important potential solution to tackle supply issues, really, to promoting equity. High-income countries, like you have mentioned, are also urged to share their surplus vaccines, and closely we are working with them through WHO platform. And the good news is that towards the end of 2021 to continue to 2022, high-income countries are also willing. Some have come willing. And the COVAX is having very high standards, though this dose sharing process is well managed. I think there is also assumption that expired vaccines are pushed. No expired vaccines would be shipped. It's highly professional, standard quality being used. And in Africa, this is a dynamic situation that is a very needing very close attention, and it is monitored. For example, I can give you several countries have doses expiring in May, June, and also July. And already about 178,000 doses have expired, unfortunately. And 1.35 million could be at risk, and we have identified 11 countries. The data collation is ongoing strictly between countries and also the regional offices. And our partners are also helping us. And what are we going to use this is we are advising the countries for evidence-based decision for quick utilization of these vaccines. So efforts are undergoing. We are not hiding it. We are closely monitoring, and no vaccine should go to waste. Thank you so much.
Absolutely. Ben, weigh in here. Your thoughts on how to address this issue.
Well, so yeah, I mean, it's a critical issue. We know how difficult the process of producing the vaccines and acquiring the vaccines have been, and now seeing some going into wastage is really not good. And we need to really maybe do more thinking on how we would address this issue. Number one, I think when I look at it from most of the countries we have seen so far within the region, with the high rate of hesitancy, the uptake has not really allowed for a consumption or utilization of the doses that have been made available. So I think number one way of addressing this is still going back to what we have discussed before previously about really engaging populations to convince them about the benefits of these vaccines. We need to do more work. I feel there is still a lot of gap in terms of what we need to do to address the hesitancy issue that will drive the uptake that is required. Without that, the upstream allocation from other countries, it might come into the country. We may still face the same challenge of vaccines lying down in the country, cold chains and cold rooms, without people coming to take up the vaccine. So there is more that needs to be done with respect to community engagement, risk communication for the uptake of the vaccine. And this is what, from our perspective as International Federation of Red Cross and Red Crescent Societies, we're trying to scale up efforts in that direction to encourage population to really dispel rumors around the myths around the vaccine that's preventing the uptake. So I think this is critical moving forward. Irrespective of how much supplies we get, we need uptake of the vaccines. We need to drive the uptake of the demand for the vaccines. Yeah.
That's great point. So as we focus on equity in the supply chain, it's just not about raw materials and consumables and vaccines on tarmacs and that sort of thing. It's about evidence and information as well. It's critically important in terms of equity in that supply chain. Thank you for that. We do have a question from the chat that's also on vaccines, pretty detailed. Let's take that question before we move on to a broader question on vaccines. So this question comes in and asks, assuming the African countries have the opportunity to receive the desired quantity of vaccine supply from the international community, what measures will African countries need to put in place to ensure steady power supply to maintain viability and effectiveness of the vaccine? So maybe just comment in terms of the criticality of the power supply as you think about equity in the supply chain. Anyone want to volunteer to take that one on?
I can try.
Measure it, please. Yeah.
Thank you so much. Yes, the energy, the constant energy supply has been a challenge, but as you may know, with the vaccine introduction supported by Gavi for the low-income needy countries, their cold chain has been changed even to solar powered cold chain. So not as much depending on electricity, but still we are not yet there to meet the demands. But even with this, with the COVID-19 vaccine, countries, those needy countries have options of expanding their cold chain capacity, and they are tapping to that. But beyond this, yes, we need also governments to make sure that investments are also real. This is part of the system. It's not only in health, but also the system. As you know, the needy, least developed countries that are really struggling with no electricity, despite having huge rivers. So investments have to go. But if we get the vaccines, definitely we have a system through the plan, using the experience of polio campaigns, measles, so many vaccine introductions. We have satellites where you can put the cold chain to ensure rapid delivery of the vaccines. And we can work it out so that we have plans, backup plans for those. Unfortunately, the vaccines expired not before they went to the field.
Right.
It's rather, another issue. I don't know if I have responded to you. Thank you.
No, that sounds great. Anyone else want to comment on that? Sounds like we've that's something that a lot of attention's been paid to, and sounds like we're in pretty good shape there. So it's not all about science and the technical aspects of supply chains. There's always a political element to it as well. And so this next question is about vaccine nationalism, and how can the vaccine nationalist actions, such as countries stopping imports or exports, be overcome to ensure equitable access to needed countermeasures? So kind of thoughts on how to approach that part of equity in the supply chain. Maybe we'll start with you, Mark, your thoughts, and then go to Ben and measure it.
Yeah, this is not my area of expertise, but just thinking of ways to collaborate through like COVAX type of mechanism or something would be the only thought I would have. Yes, thanks.
Okay. It's a bit of a hot potato, Mark. No doubt about it. Maybe Ben, your thoughts on you want to touch this one?
Well, just similar to Mark, that's not my area of expertise, but I think, this is more from a political engagement at a global level and commitment at the global level. So my initial reaction or reflections on this kind of thing is, the COVAX facility has set an example of what could be done. And we also know of various initiatives at the global level that have tried to ensure not just advocacy around bringing resources together or synergy in response, but also ensuring that we have a shared and common goal with respect to addressing humanitarian challenges. So what I will be seeing is this has to be moving forward to address this vaccine nationalism, is setting up a similar structure on the long term. I don't think the COVAX facility should be temporary moving forward. it should transform to something more robust that it looks beyond just the COVID-19 vaccine, but as we are talking about future pandemics, such a structure or system being in place at the global level could start making plans ahead for the future pandemic and ensuring the political engagement and commitment to address this kind of global issues are put in place with appropriate frameworks that would ensure that this can happen on the ground. So this will be my thinking. As I said, this is both, it's not just technical, but has a political dimension to it that needs to be brought to play. Yeah, over.
Yeah, definitely, Ben. Measure, do you want to opine on that one, or?
Yeah. Thank you so
Please.
much for the opportunity. Thank you so much. You know, if there was no COVAX, I wonder, would Africa get the vaccines? Would African countries get the vaccines? That's also a very good question to ask, because it's in the equitable access is in the heart of COVAX mission. 47 lower income African countries got the vaccine at no cost through the COVAX advanced market commitment mechanism. So I totally agree with Ben. We should take this forward. And I know COVAX is continuing beyond the 20% to really supply more vaccines, because the 20% is looking into 3% of the healthcare and social workers, and the 17, those elderly plus those with comorbidities. Otherwise, we wouldn't have gotten the vaccine, in my thinking. The multilateral solutions are very key. You know, the more we delay the pandemic, no country will be safe because mutations will happen and it will come back to other countries. But India has walked the talk on vaccine equity, really. Majority of our AstraZeneca vaccine has come from India, really. So we want to hammer on the dose sharing from high income to low income countries. This is very critical. Manufacturers are under extreme pressure, but they could also share their excess supply of raw ingredients to potential countries. We have few like South Africa, Tunisia, and so on, where they can have, you know, the finished product at our end. So the intellectual property, the technical know-how, relevant data, it may not happen now, but as a long term, that has to be taught if we have to learn from managing a pandemic. Thank you so much.
Great. No, really nice intervention. We'll come back to a question around technology transfer. But before doing that, we have another one in the chat. I'll just read it out and see if any of you want to respond to it. As an example, Pfizer created a system that a scan of a vaccine vial links to the up-to-date stability data for that specific vaccine lot, and hence did not include an actual expiry date on the label. Is this a system that could be harmonized for all vaccines? Anyone want to respond to that?
I would just say that's a really good question. I wasn't aware of that, and I think that's a very good question to pursue. Yes.
Obviously, there's a regulatory component to that and a data veracity. But let me just thank the listeners for those thoughts and questions. Let's turn to technology transfer and maybe from where you sit, what are the best ways to build technology transfer and to empower the local manufacturing capacity? And here, Mark, maybe we'll start again with you on that one.
Yeah, one of the things that I've been thinking about is how we can have capacity that's up and running so we don't have to start from scratch. So in other words, when we start building capacity, say in Africa, we have a vaccine that is being made that we can then put on top of that the new pandemic vaccine. And one idea there would be a vaccine that you need every year, like influenza. So you have the vaccine being made, and potentially, because, you know, mRNA vaccine started with flu, they were working on flu, they just didn't get there as fast as obviously COVID. But now I think the potential will exist. There will be an mRNA vaccine for flu. And once you get to that point, going forward as new pandemic viruses appear, if you had a manufacturing capability globally that enables you to make mRNA vaccines, you'd be able to switch very quickly. You'd have the, the infrastructure in place, the technical know-how, the employees that have the experience, et cetera. So that's sort of one of the ideas. In fact, we're thinking how we might be able to help in that area. Thanks.
Great, thanks, Mark. Quick interventions from either Meseret or Ben on this topic.
Thanks. Let me try because even for the other vaccines, if not COVID, most of the clinical trials happen in Africa. So why not the production? We are not saying it should be within 5 years, no, but at least start slow with the pack and fill. Already Senegal has been producing, for example, the yellow fever vaccine. It's one of the 5 countries globally which produces yellow fever vaccine. But we have potentials identified already around 5 countries who can do quick packing and filling. Let's start with those and then progressively be able to produce, because Africa is 1.35 billion population. So, and then with urbanization and upcoming, it will be a risk for further pandemics. So I think this intellectual property, technical know-how transfer should be there. And the African Vaccine Manufacturing Initiative also comes in very handy. Heads of states have been very vocal. The Southern Africa president, I know the Rwanda president, we want this really, and we do. And there will be market for it as well. Our communities are in their need. Look at what happened in Ebola. No country will be safe if we don't also put investments in the needy countries.
Great.
I know it is political. That's my part.
Thank you, Meseret. I'm noticing that we're at the half-hour mark, and we need to wrap up. So Ben, I'm going to let you have the last word, either on this topic or anything you want to intervene on, and then we'll wrap up.
Thank you. So my last word will be considering every aspect of what we have talked about, whether it's technological transfer, local manufacturing capacities, addressing the issues of inequity or distribution supply chain challenges. It will be that it's important that there is ownership at the national level, at sub-national level, and at community level, irrespective of what we're talking about. If we want to address supply chain issues, there should be deep involvement of the people who are going to be beneficiaries of this. If we're talking about local manufacturing, technological transfer, there should be ownership and responsibility from the government at the national and sub-national level. So this would ensure ownership, sustainability, and of course, in the spirit of localization, as we're talking about globally, that every country should be able to appropriate support aid in its own context and ensure that it's appropriated as required and tailor-made for their context. So for me, this will be my last closing remarks on this panel. Thank you.
Indeed, Ben, the community, local, and country voice is paramount in equity in the supply chain, and it's a lesson we need to learn and a lesson we need to enact. So we've come to the end of our time. First and foremost, let me thank Meseret and Ben and Mark for their astute interventions on a wide range of topics related to equitable access and allocation of critical supplies. Clearly, we still have much to learn, but the discussion today, I think, provides some useful lessons learned to make us better prepared for influenza and influenza pandemics specifically that are surely to come. So thank you to also to all of who joined this discussion. This concludes the workshop for today. However, the workshop is not over. Please do tune in again on Tuesday, May the 25th, 8 to 11 a.m. Eastern Daylight Time for the third and final day. And all be well.
Thank you, David.
Thank you, David. Excellent.